A very good afternoon to one and all of you. My very special thanks to Dr. Rohit and his team for remembering me for this very interesting conference. Taking you on. Okay. So my due is to just give you a bird's eye view of customized cross-linking, just some idea at the end of it, because it's actually come up in the last couple of years and being done in some of the centers, and it's just being understood. So essentially, all of us know that cross-linking has come to be accepted as a holy grail in keratoconus management by the very property of increasing the corneal biomechanical resistance and inhibiting the intrinsic anticollagenase activity. We also know that there are two types of reaction. The type 1 is slow and anaerobic, and the type 2 releases the signet oxygen, which actually helps in combining the two proteoglycans and bring about a more effective cross-linking. But then, now we are in an era where we are talking about accelerated cross-linking, where you're using high fluence and time durations, shorter time duration, and in this content, what thought came to our mind, especially when we are increasing our energy levels, the cross-linking was not as effective as a 3 milliwatts or a 9 milliwatts was. So the thought came that the oxygen which was critical for cross-linking was probably, as it was getting depleted, it was not getting replenished. So then came the concept of using pulsed fractionation of ultraviolet radiation, wherein you could use pulsed treatment of 1 second off and 1 second on. And this probably is being understood could be a factor which ensures that you are working in a more oxygen rich atmosphere, although there are still a lot more queries whether this 1 second on and 1 second off is enough. So in this context, customized cross-linking was just one more piece to this whole jigsaw puzzle which we've been discussing the whole of today. There are thoughts now which tell us that it is a focal biomechanical weakness. So why not we focally target this area of the cornea alone and thus strategize to redistribute the biomechanical stress, and in this thought process evolved customized cross-linking. So in the next few minutes, I would just like to brief you on the rationale, planning and the results in the different series. So again, customized cross-linking, why? Yes, it's a focal disease. So why not deliver energy on that area than wasting it in the surrounds? Do you have better results? There was this study where they used the Brilliant microscopy, and they found that the viscosity of the eye cornea in the area of ectasia was significantly lower compared to the normal. And then they also found that the area in the keratoconus eye, which was away from the ectatic area, seemed to have nearly the same viscosity as that of a normal eye. So then it made more sense to think, why do you go ahead and cross-link the entire cornea? There's again this study which came up, was studied by Dupes et al., which is a finite element analysis study, wherein he has compared a focal treatment to a conventional treatment and has come up with the understanding that this focal stiffening in a weaker area, that the focal area, flattens the cone significantly with improved visual functions. So then evolved thought, why not tailor make it depending on the location of the keratoconus or the stage of the keratoconus, and this KXL2 system came into evolution. What is most important is we need to center it around this particular ectatic area. How we go about it? There are different protocols which have evolved. You could either do it in a sectored fashion, wherein in the area of cone, in the area of cone, that where you give highest energy is 15 joules, in the peripheral area 10 joules, and in the outermost area 5.4 joules. Or you could do it as a concentric treatment, focus it around the area of the posterior float of the maximum elevation, and then have your circular areas. You could do it on a 3, 5, 7 millimeter zone, circles, or 2.5, 5 or more. You could have sectors, you could have arcs, you could have different designs. The essential idea is to focus it on the area, highest energy in the area of the steepest cornea or the thinnest cornea. So this was one other way of approaching it, wherein you have concentric circles designed. The inner circle is 15 joules, and herein they define parameters as to how you measure that shortest diameter or the vertical extent of this diameter. And again, these are not necessarily the only way of approaching it. So herein you first need to identify the centration. You could look at the curvature map and look at the steep case, and then you could grade it as to how you would treat it. You could look at the pachymetry map and look at the thickness gradation and concentrate the cross-linking in the thinnest area, or you could look at the posterior float elevation and center your treatment around the posterior float, where that is that you treat around the highest energy in the area of highest elevation. So first you define your x and y coordinates and then concentrate to treat around the posterior float if that is your modus operandi. And herein, in this particular instant, you first define your shortest vertical diameter and then you define your longest diameter and add 1 to it. It may not be feasible in all kinds of cones. The other way of doing it is by going by the curvature maps, wherein it is all anyway, it's a patterned treatment which is being given. You could go ahead and give in the 48 diopter of K max, you give for 8 minutes, you give pulsed ultraviolet radiation. That would be your zone of treatment, and you treat it for 8 minutes with 7.2 joules as your starting point. And then between 48 to 52, you go on to 10 joules in that particular zone, so that the outer zone gets masked. Then the intermediate and the inner zone are being exposed at that point to 10 joules for 11 minutes, that is 8 plus going on further. And then in the steepest area over 52 diopters, you give your maximum energy, and at that point of time your intermediate circle and the outer circle are masked, they are not exposed to the energy, and the final overall treatment comes to 16 minutes. And this is how the treatment is planned out in this particular situation. So then you would debride about 7 millimeters of the epithelium around the asymmetric focal area and instill 0.1% of Vibex rapid for 10 minutes, and then pattern the kind of pattern which you have decided for this particular treatment is treated with 30 milliwatts per centimeter square, and as I had said earlier, it's going to be a pulse radiation. So this could be one pattern which is defined as a sector pattern, but different studies is what I'm going to tell you about. One was the study of Casagne et al., wherein he has shown that he has compared a topo-guided cross-linking with the conventional cross-linking, customized cross-linking with conventional cross-linking, and he has shown us the flattening of K is more significant with customized cross-linking compared to conventional cross-linking. He has again shown us that the gain of lines of uncorrected best corrected visual acuity is again better in a customized focal treatment as against the conventional cross-linking. He has also told us, he has compared a confocal microscopy picture. He has shown us that the hyperreflectivity in the area of apoptosis is there in both, but it is definitely not as significant in a customized cross-linking, or not as rampant as it is in the conventional cross-linking. The typical demarcation lines of 3 zones of treatment is visible on anterior segment OCT. This is again another cross-linking study which was done on the different beam profiles by Rohit Shetty and co, which tells us that you could use different approaches with each of them having their own optimal outcome. You could decide on having a sectoral kind of treatment strategy for a decentered cone or an oval treatment, or if it is a centered cone, you could plan it having a circular treatment around that area of cone. As far as the safety is concerned, there are different studies which have again said that the endothelial count has been stable and the overall energy delivered is less, which is what is more poignant about this whole process, and the haze formation is comparable to standard cross-linking. There were n number of proponents who came up, who did a 12-month study or a 6-month study in about 20 eyes or 21 eyes. They had their own protocol. Some had started off with the lowest energy of 4 joules, some started with 7.2, some started with 5.4, But essentially, the idea to be taken by us is we could redistribute the energy such that you do not focus the whole lot in the entire cornea. There were different studies which told us that the uncorrected visual acuity, the best corrected, the topographic evidence of flattening, and all of these which are there was definitely very much encouraging. There was a study again by Costomized et al. Which tells us that, as you could see, that the uncorrected visual acuity improved over 12 months. The best corrected visual acuity has improved over 12 months. Has improved over 12 months. And if you look at the cylinder, there's a significant improvement in the cylinder correction. If you look at the Kmax, what is interesting is that the changes in the Kmax are more significant than in the K mean and in the K average. What? Kmax. And then what else you understand is the changes in the coma are more significant than in the spherical aberration, which are all interesting assumptions which have concluded in his study. He has also done a confocal microscopic study at 1 month and 6 months in their group, and herein again the areas where the higher energy levels were given, the demarcation lines were deeper as compared to the area of lesser energy levels. The hyperreflectivity in the areas of apoptosis was seen, but then when these eyes were seen after 6 months, the regeneration of the epithelium had started, which was again quite an encouraging sign, although the demarcation lines were still quite visible. The other interesting finding was that the demarcation lines were deeper in the area of the treated area as against in the peripheral areas where it was more superficial. And again, the nerve density levels were also more in the treated areas and less loss of nerve density in the peripheral areas, which tell us that it was pointless to treat areas which were not ectatic. We did our own small study of 30 eyes, wherein we compared customized cross-linking with regular cross-linking. And what was again interesting and reiterated my other studies which I related to you was there was a significant change in the Kmax, the inferior superior asymmetry, and the best corrected visual acuity in the customized cross-linking. There was this evidence that there was a significant flattening of Kmax as compared to the conventional cross-linking. And again, the inferior superior asymmetry index was definitely better. The demarcation lines were also quite obvious in the custom cross-linked eyes, and the endothelial count, if you can see those values, were comparable and stable. This is again just one study which I'm showing you, one of our patients. The pre-op BCVA was 636 with a best corrected visual acuity of 612. And here the vision improved with a significant reduction of cylinder to a BCVA of 6.6. And it's so obvious that the cone is more symmetric, and further to it, the inferior superior asymmetry shows there's a significant improvement. Again, if you can look at the coma values, I don't know whether it's clear, there is a definite reduction in the coma, the spherical aberration, and in the total higher order aberration following this cross-linking. And the specular microscopic study in our study, pre-op and post-op, were quite stable. So essentially, as I would like to conclude, I'm sure I've driven home this message that the material property distribution is definitely as appealing in customized cross-linking, why not more? And there is a compensatory steepening of the surrounding area. In other words, we are attempting a better regularization of the cornea. The decrease in the inferior index is more than in the superior index. And there are obvious evidence now in these few groups which have been studying it that there is a biological difference in the area treated in the cone and in the surrounding area. And there is also an evidence that there are certain changes in the area superior to that being treated, which tells us that there is some kind of a chemokine release, there is some amount of diffusion and induction of changes, which you could call it as a sponge effect. There is evidence now that you could increase your energy dose with reduced exposure time, which is what we gain to understand, and this sort of expands our scope of treatment entirely. It makes you believe that there is this combination therapy which is possible, and you could look at doing a variety of patterns specific to the patient's topography and definitely with analysis, hope for better results. So we've come a long way in our understanding. The holy grail of cross-linking is not just the regular Dresden protocol, but it expands its horizons to a huge variety of situations. Why, as we heard yesterday, it is even looking at correcting these small refractive errors. Thank you.
Thank you so much, ma'am. Okay, sir has one question. Sure.
My main concern, Dr. Chitra, would be about the safety. You did mention about it, but I would be alluding to what Dr. Hafizi said in the morning, that if you are doing it in a thin corneas, you probably would like to reduce the fluence. The diagram which you showed, you are increasing the energy in the thinner areas and which are more ectatic. So are we not damaging the cells in that particular area?
You are increasing the energy, but the duration of treatment in that time is less. So essentially you are treating the way the time was, that it's altogether 16 minutes. So the one's full circle, like it comes like the beam profile, the way it comes, one is for the full area of to be treated. So that is for 8 minutes, and that is either at 7.2 or 5.4 joules. Then that beam goes off, and then the intermediate circle and the central circle alone are being illuminated, which goes on from the 8th minute to the 11th minute. And then the last is the 11th to 16 minutes. It is not that for full 16 minutes you're going bang on in that area. So you're just giving high energy for a shorter duration of time, more focally in that area.
So the 16 minutes is not fully illuminated. Okay, yeah, that makes sense.
Just have two comments. Thank you for the nice presentation. I think there are two issues, or two topics. One is the endothelial threshold damage, the damage threshold that was published years ago to be 0.36 joule per square centimeter at the level of the endothelium, and this is probably not correct. This is why nowadays in customized cross-linking you can go so much higher in the center over the cone without damaging the endothelium. And so this explains what I mentioned before. In our thin cornea adaptation, we need to adapt this algorithm to new threshold levels. And the other issue is pulsed cross-linking. We showed that whether you do pulsed or continuous light with the different fluence is just the same effect. So I don't believe that it is the pulse that is doing the benefit. I think it's the gradient overall, and probably you could do this with continuous light too.
I do agree. We are not very, this is just something which is happening now, that you can't totally conclude on it, but this far the results have been good is what I try to conclude. Yeah.